Good afternoon and welcome everyone. My name's Nicole Sadler and I'm the Head of Policy and Practice at Phoenix Australia Centre for Post-Traumatic Mental Health. Phoenix Australia is a not-for-profit organisation and for 25 years we've been dedicated to reducing the impact of trauma and post-traumatic mental health problems in individuals, work groups and the community. Thank you for joining us today to discuss understanding dementia and trauma in aged care. I'd like to start our session today with an acknowledgement of country. I acknowledge the traditional owners of the land where I'm situated today, the Ngunnawal people, and those are the lands where each of you is situated. We acknowledge that the lands on which we meet were the place of age-old ceremonies, of celebration, initiation and renewal, and that the local Aboriginal peoples have had and continue to have a unique role in the life of these lands. Let me briefly outline the background to this project and how today's webinar will run. Phoenix Australia is one of 4 organisations funded by the Australian Government Department of Health to deliver a COVID-19 grief and trauma response package to the aged care sector. The other organisations are Australian Centre for Grief and Bereavement, Older Persons Advocacy Network or OPAN, and Dementia Support Australia, who are joining us today for this webinar. Today's webinar is part of Phoenix Australia's program of work under this funding. This is a second in a series of 4 webinars. The first, Identifying and Managing Trauma Within the Aged Care Sector, was held in November 2020. In that webinar, we provided information on the impacts of trauma, including for those in residential aged care, and how applying trauma-informed strategies can assist residents and their families, carers and managers. In case you missed that webinar, we'll send you the link to the recording along with the link for today's webinar. During today's webinar, Dr. Richard Bonwick will discuss dementia and trauma, including the various types of dementia, an explanation of trauma, and the interactions between trauma and dementia. Jane Nursey will outline how managers and staff can manage dementia and trauma in aged care settings, highlighting the benefits of using a trauma-informed care approach. Richard, Jane and I will then discuss a brief case vignette to illustrate some of the issues raised in the 2 presentations and ways to manage them. I'll then introduce Mr. Ash Katush for a discussion about the role of Dementia Support Australia. And finally, all of the speakers will come together to answer any of your questions about managing dementia and trauma in aged care settings. Just before we start the presentations, I'll cover some housekeeping to ensure you have the best experience today. As you can see on your screen, there are 2 boxes below the webinar stream. One is the chat box where we encourage you to comment and chat to each other by entering your name and clicking Join Chat. The other is a Q&A and polling feature. We really encourage you to ask questions, but also to vote for questions you'd like our speakers to respond to. To do this, you type your question and either enter your name or leave it blank if you wish to remain anonymous. Should you see a question you want to vote for, hit the like button to ensure that we answer it today. There'll also be a poll towards the end of the event. Please complete this by navigating to the Polls tab within the Q&A. I'll let you know when the poll is launched. Should you experience any technical difficulties, please navigate to the chat box at the bottom right of the page and our team will be able to assist you immediately. I'd now like to introduce our first presenters, Dr. Richard Bonwick and Jane Nursey. Dr. Richard Bonwick is a psychiatrist who specialises in old age psychiatry and treating ageing war veterans. He's spoken and written nationally and internationally on a variety of topics in old age psychiatry. He's an expert clinical advisor to Phoenix Australia and an honorary clinical senior lecturer at the University of Melbourne. Jane Nursey is Director Clinical Services at Phoenix Australia. She's a clinical neuropsychologist with almost 30 years experience in the field of post-traumatic mental health as a clinician and manager director of programs and services in mental health, aged care and the disability sectors. She has extensive experience in providing policy and service development advice and training in the field of post-traumatic mental health to a broad range of government and non-government agencies. First of all, I'd like to welcome Richard.
Thanks for that introduction, Nicole, and just like to welcome everyone to today's webinar. As an old age psychiatrist, I'm often frequently asked, what's the difference between dementia and Alzheimer's disease? And dementia is a term to describe irreversible brain deterioration, resulting in a decline in brain function and particularly in cognition. In the year 2020, there are approximately 460,000 Australians who suffer dementia. Alzheimer's disease is the commonest form of dementia in these people, making up about 70% of those cases. But there are more than 100 forms of dementia. Many of them are extremely uncommon, and even people like yourselves who work closely in aged care may never encounter any of these. Each of the dementias has a different set of typical symptoms, a different path, and a different outcome. Dementia Australia lists Alzheimer's dementia, vascular dementia, Lewy body dementia, frontotemporal dementia, alcohol-related dementia as the 5 commonest types, and I'm going to briefly speak about each of those. Firstly, Alzheimer's disease. The onset of Alzheimer's disease is typically in the 80s, although it can occur as early as 40 years of age. Sufferers typically experience lapses in memory for recent events and problems in finding the correct word for everyday objects. Symptoms can fluctuate, but typically decline in steady and noticeable patches over months to years, with worsening to severe memory loss, confusion, and an inability to manage day-to-day tasks. Each stage during the deterioration of Alzheimer's dementia can be complicated by psychiatric problems such as depression, anxiety, and paranoia. Vascular dementia arises as a consequence of multiple small strokes to the brain. So it is commoner in people with risk factors for strokes, things such as hypertension, diabetes, heart disease, elevated cholesterol, and smoking. And all of these are extremely common in the Australian population. Because strokes can occur anywhere in the brain, the pattern of symptoms is less predictable and depends on the location of these strokes. Decline is often quicker and more sudden than Alzheimer's dementia. Common psychiatric complications include frequently depression. Vascular dementia and Alzheimer's dementia frequently coexist, and this is a so-called mixed dementia. Lewy body dementia is characterised by Lewy bodies named after the doctor who identified them. These occur in brain cells, causing cell death and a progressive dementing illness. It has an unusual triad of symptoms: visual hallucinations, symptoms like Parkinson's disease with prominent tremor, stiffness, and a slow shuffling gait, and rapid fluctuations in levels of concentration or consciousness. Sufferers can change rapidly from lucid to vague or even alert to drowsy. Deterioration in this illness is rapid, often occurring over only a few short years, and in my experience there's often an early requirement for aged care services due to the impact of the above symptoms. Frontotemporal dementia displays selective damage to the frontal and to a lesser extent temporal lobes of the brain. Frontal lobe function is vital to social behaviour, judgment, planning and self-control. Typical symptoms are a change in personality and behaviour, often with disinhibited, impulsive, socially embarrassing and even aggressive behaviour apparent and problematic. If the temporal lobes are also involved, language problems also occur. Sadly, this dementia usually arises during the 50s or 60s, and there is a rapid decline over a few short years. Alcohol-related dementia results from brain damage caused by long-standing heavy alcohol consumption, often arising as early as the 50s. Alcohol seems to be more selectively affect the frontal lobes of the brain, resulting in a clinical picture a little similar to that I described for frontotemporal dementia. But it can also impact on memory function, sometimes very severely. There is a good description of each of these dementias and some other forms of dementia on the Dementia Australia website, which I've listed there at the bottom of this page, and I'd certainly recommend this to people. Most elderly Australians in aged care facilities have experienced multiple traumas through their long lives: war, a serious accident, a natural disaster, a personal assault, and most recently, we've all experienced multiple traumas associated with the COVID-19 pandemic, none more so than aged care residents and staff. As discussed in our first webinar, aged care residents have also experienced and likely continue to experience a number of traumatic events attached to both entering and residing in aged care facilities. And as indicated earlier, you can access that first webinar for that issue to be discussed further. Next slide, please. Thank you. There is a rich interplay between trauma and dementia in our aged care population. Lifetime traumas may contribute to the onset of many of the dementias already described. Traumatised individuals are more likely to abuse and become dependent on alcohol, risking alcohol-related dementia. Repeated traumas can result in poor lifestyle choices and poor utilisation of available healthcare, causing risk factors which may result in vascular dementia. Even a single severe traumatic event, resulting in post-traumatic stress disorder, has been shown to increase the risk of developing Alzheimer's dementia, according to recent long-term studies of American war veterans. The presence of a dementia may result in past traumas being re-experienced. In Alzheimer's dementia, recent memories become less salient, and strong past traumatic memories, previously quiescent, may emerge to the surface. This can affect current behaviours in the aged care facility, and I've found this is a particular issue in war veterans who are suffering dementia and are residents in aged care facilities. The presence of dementia may result in misinterpretation of caregiving as a traumatic event. Day-to-day personal care, showering, dressing and feeding may be incorrectly perceived by the resident as traumatic due to impaired cognition, plus any past experience of physical trauma. There could be a lack of understanding of instructions and explanations due to language impairment, or a misinterpretation of actions due to poor judgment, for example, as may occur in frontotemporal dementia, or the presence of hallucinations such as Lewy body dementia. Then the aged care resident's response to these perceived traumas may be influenced by the presence of dementias also. A regular caregiver or staff member may not be recognised due to short-term memory problems. Verbal responses may be hindered by language impairment. Disinhibited or inappropriate aggression may occur due to poor frontal lobe function in frontotemporal dementia or alcohol-related dementia. To further complicate this very, very difficult picture, there are also high rates of so-called behavioural complications in all the dementias. Anxiety, depression, psychosis, aggressive behaviour, wandering, restlessness, vocalisations and yelling out are all too common, and I'm sure many of you have seen those in aged care residents. Unfortunately, the nature of this presentation limits and the time limitations prevent a greater explanation of these very important aged care problems, but they are certainly worth considering against the background of dementias and trauma which we've discussed. Now I'll pass over to Jane Nursey, who will discuss trauma-informed strategies to support residents in aged care.
Thank you, Richard. And hello, everyone. When we think about supporting people who have a trauma history, and we think about trauma-informed care as being the best approach. For those of you who might have attended our earlier webinar, this slide might be familiar to you. But the concept of trauma-informed care is really a fairly simple one. It is around the idea that everyone involved in the person's care and support will work with that person in a way that allows them to feel safe and minimises any chance of them being re-traumatised. And there are a number of principles that sort of help to work towards that goal. Certainly the idea of, in whatever way you work with them, whatever you're doing, you're promoting a sense of safety, not just physical safety, but psychological safety and emotional safety, and that's taken into account in your interactions, that you're developing a sense of trust with the person, that you're providing them with choice and control over what's happening to them, when and how, that you're connecting them in with others and maintaining their social connections and connections with people that can support them and make them feel safe. Understanding people who enter residential care who might have a history of trauma and dementia means really taking a trauma-informed care approach to working with them. Many residents might come in with them having really good strategies to manage both their trauma symptoms and perhaps some of their early dementia symptoms as well. But as time has gone on, they might have become less powerful, less useful, and are no longer working for them, which means that they're even more vulnerable at the point of coming into residential care, where there's additional stresses and potential traumas that they need to face. We can think about the strategies that you can put in place to support them as falling under those main principles of trauma-informed care. So helping them feel safe is perhaps the primary one and the primary responsibility of everyone in the residential care setting to help manage people with trauma and dementia. Things like being aware of how you're coming across to them. What sort of body language are you using? How are you modulating your voice? Are you shouting? Are you yelling? Are you using words that they don't understand? Are they shying away from you because there's something about the way you're speaking or presenting that makes them feel afraid? So being cognizant of that, being much more aware of that when you're around people with a trauma history. Communicating at a level where they do understand simple sentences, constantly reassuring them that who you are, what you're doing, that they are safe and that you're there to support them. And repeating any instructions, repeating what you are doing, particularly for those who might have become a bit more forgetful. For those with language impairment, it's about using sign language or pictures or other things to get across what you are doing so they have an understanding of that. It's easy to ignore people who appear to be unable to comprehend or engage in conversation with you and think that they won't understand anyway. The reality is that's not true. They're going to have a sense of what is happening around them, and they're more likely to perceive it as being threatening to them, particularly if someone hasn't taken the time to spell out what's going on. So keep them informed. Follow through with what you say you're going to do. Don't promise to do something, come back to them in half an hour with a cup of tea, and then not have that happen. That's easy to happen in a residential care home where life is very busy and other emergency issues arise. But as much as possible, the person with trauma history, and particularly dementia over the top of that, requires consistency and routine and dependability in the people who are working with them. Maintain routines, provide some behavioural strategies that the resident can use to help calm themselves. And maybe that's about having a soft toy or a piece of material that they like holding that calms them, or a certain piece of music or a certain picture to look at. Some calm breathing as a simple resource. Making sure that noise levels are reduced. Providing choice and control is also really important. So as I said, explaining what you're doing and as much as possible giving them some choice in that. So maybe it is about, if they aren't able to cope with a range of different people managing their ADLs, finding out who are the people that who they do feel comfortable with, and arranging as much as possible to have those people only working with the client around their ADLs. Asking them about what makes them feel safe, and trying as much as possible to build that into the day and into the routine. Providing education around trauma and dementia, helping them understand what they might be feeling and what might be triggering that, and bringing a counsellor in to help with that if it's beyond your capacity or the time that you have to do it. Keep them engaged in pleasant activities and hobbies and other things that are familiar to them and that they are able to do, that are part of their strengths. And invite them to participate in those activities. Don't just force or put them in a situation without having a conversation with them first about it. keep them oriented, have those notice boards in their rooms where their schedule might be written down, where there's reminders of where they are, who are the people around them, those sorts of things. A really important thing around managing trauma is remaining connected with other people. People who are isolated are at much higher risk of really developing those more difficult, challenging behaviours, but also things like depression and anxiety disorders and even post-traumatic stress disorder. And we know from the previous presentation that PTSD can take a bit of an up and down path. So it might be that someone comes into your home who has suffered from PTSD in the past, but perhaps hasn't shown many signs or symptoms for a while. But coming back into residential care, that might get re-triggered just because of the changes and the fear factors are involved in that significant life change. So educating yourselves, educating carers and families, members, so that they're aware of what to expect, but also what might be some strategies to use. Engaging, if the person's able to, a counsellor where they can actually talk through perhaps some of their trauma and some of the issues that are of most concern to them. Don't leave them alone, particularly when distressed. That, as I say, that isolation is going to enhance those feelings of fear and anxiety and sadness. So, as much as possible, providing someone to be with them if they're highly distressed whilst they calm down. Support the use of well-learned skills and hobbies and activities, as I say. So that gives them a sense of empowerment, gives them a sense of control, but also keeps them distracted and active, where they're not left to just be lost in these old memories that might be sitting there with them. I just want to finish by saying a quick word on managing anger and aggression, because that obviously is one of the most difficult things to manage in residential care, but also perhaps one of the most common behavioural problems. And trauma-informed care approaches very much lend themselves or are well set up to manage anger, in that they are again about allowing the person to take the lead, to acknowledge what's going on for them, and to be heard. So important that you remain calm. To keep your body language neutral, to keep your words neutral, to not in any way escalate the situation by your response to it. Acknowledge their distress, acknowledge and let them know that you're there to help, and that you're there to find out what they need, what they want, and help them with that. Respect any boundaries that they have. If they don't want people to come up and touch them, respect that, particularly at the point of being distressed, if it's safe to do so. Provide them with options for de-escalating and getting out of the situation that they're in. So it might be being taken back to bed. It might be sitting out in a chair somewhere on their own for a while. It might be going for a walk around the garden, but giving the choice and being familiar. Part of trauma-informed care is staff being aware of what are the things that are going to help to de-escalate this person in particular. What are the things that calm them down? What are the things that they feel safe with? Use repetition, particularly for those with dementia. Have a safe place in the home, in their room, that is comforting to them, or maybe a person on staff who is the safe person for them. And use behavioural strategies. Don't just rely on talking. Use distraction, use activity, use calm breathing. I want to now move on to just present the case study to you, and then Richard and Nicole and I will have a chat about this. So this involves a lady called Louise, a 79-year-old woman who'd recently moved into a residential aged care facility. She has 2 adult children who visit her on a regular basis. Her personal history reveals that she had had a fairly difficult life. She grew up in poverty. She was subjected to several episodes of sexual abuse from an older man when she was in her late teens. She married early, in her early 20s, and had her children in fairly quick succession after that. Her husband was physically and sexually abusive towards her, and she suffered numerous episodes of depression throughout her adult life as a result of that abuse, which meant that she could only work intermittently as a domestic aide. 4 years ago, Louise's daughters noticed that she was becoming forgetful and getting confused on occasions. She began having arguments with her neighbours and would then go and lock herself in a house and not let anyone in. She became increasingly at risk during that period. Last year, she was formally diagnosed with moderately advanced Alzheimer's disease. She was then admitted to residential care about a year ago and spent the first 14 days isolating in her room due to COVID protocols. Her family were unable to visit her regularly because of COVID restrictions in place. She's had a difficult time settling into care. She refuses to shower. She started becoming increasingly aggressive to the personnel care assistants and nurses who try to bathe and nurse her. She becomes very distressed if anyone tries to approach or touch her, especially male staff. So we'll hand back now to Nicole to lead the discussion.
Thank you very much, Richard and Jane, for those presentations and for presenting that case for us. Richard, what are the key things that stand out for you in this case of Louise?
I guess the first thing, the audience will be pretty familiar with this sort of problem. It's a day-to-day issue. I think she's a very good example of that. As I was listening to the vignette, I thought it's amazing how much information you can contain in a few brief paragraphs, and how that really adds context to the problem that the last paragraph described of refusal of care and aggressive behaviour. But what I like to do when I'm approaching someone, and I think this works equally well for non-medical people, is just to kind of have a few key points that I've got in my head when I'm dealing with a person. And I think here it's really very nicely laid out for us. A very extensive and tragic past history of physical and sexual abuse that's going to permeate every behaviour that she manifests through the remainder of her life. So I like that very much in the forefront of my mind. A past history of depression, clinical depression I'm assuming, that could re-emerge at any time. And so if I was approaching, I'd always be thinking, is this lady becoming depressed again under new stresses and traumas? The expression moderately advanced Alzheimer's disease means that she's very likely to have very poor short-term memory, and also possibly impairments of either expressive and or understanding language. So she may have difficulty understanding things and also difficulty expressing herself. So again, approaching her, I'd want to be carrying that in my head. Entering the aged care facility at the beginning of the pandemic and all the changes that resulted there, I think are just worth being aware of carrying forward. Those of us in Victoria, and I spoke to many aged care residents, people were literally locked up in isolation for 14 days for longer. Staff were loaded up with PPE and looked like probably people from outer space coming into their rooms. It must have been an incredibly traumatic time for so many residents. And I guess the other thing is really sort of holding all that and then thinking about how that deals with the current issue of her refusal for showering and her aggressive behaviour.
Thanks, Richard. It's one of those cases that probably seems quite complex, but as you said, is probably pretty familiar to people who are watching today, and they are the type of cases that people can be expecting to see in aged care, particularly over the last 12 months and into the foreseeable future, unfortunately for us at the moment. So, Jane, what are the sorts of strategies that you think might be helpful for staff to be employing when they're trying to support someone like Louise?
So look, I think trauma-informed care is designed exactly for these sorts of cases, really. And I think one of the first things that's going to be really important is that all staff are aware of exactly what her history is, and that they understand that, particularly with a Model E advanced dementia, any aggressive behaviours or challenging behaviours aren't necessarily going to be under her control. She won't be able to just switch on and switch off. But she's going to need management strategies to help with that. But also the idea that there will be a number of triggers for her in this environment that are going to really increase her distress, increase her anxiety and fear that she might not be able to articulate at the time. So for staff to be really aware of that and prepared for dealing with that. And then being able to go and ask questions about what might make her feel safe, understand really what are the particular things that might contribute to her being triggered. If it's male staff that make her feel unsafe, then as much as possible, staffing her with female staff. If there's a particular individual that makes her feel unsafe, then as much as possible, not scheduling that person to be working with her. I know there are limitations on doing that, but these are really important principles of trauma-informed care, of really trying to work with what the person needs in terms of ensuring safety. I think having things like a board in her room where her schedule is there, she can be reminded of what her schedule is, so it's not going to be a surprise when somebody comes in to take her away for showering, and that it's orienting her to where she is and who the people looking after her today are and those sorts of things. I know they're fairly regular things that happen, but really important for people, extra important for people with trauma and dementia. The body language, being really careful about that, not yelling, not shouting, not using any sort of aggressiveness in body language and that sort of thing. Having a safe space to return to if she does escalate, and just allowing that sense of control to start coming back in when she's feeling being aggressive. I think other things like the importance of keeping her connected with others is really important here as well. So actively scheduling a schedule of visitors, whether it be family and or others, or even just walks with other residents or walks with other carers, I think are going to be really important as well, just to help maintain a level of management of her anxiety and calmness. That means that escalation isn't going to happen, and hopefully as often. So I guess there'd be a number of other things we could talk about, but that'd certainly be some of the main ones.
Yeah, that's a pretty good list. And I think that one of the nice observations that you've both made is the fact that sometimes things will come up along the way. So what you may have assessed and strategies you put in place when someone is transitioning into residential care might need to be reassessed and changed over time as the person's, perhaps the strategies that they've used very successfully over time are not working as well anymore, or perhaps they're being triggered by things that used to be under control or by things that are new for them. So it sounds to me like this becomes something which has to be ongoing in terms of a care plan for the individual. Jane, I'm also interested in what sort of advice you might give to Louisa's daughters, to her family, about trying to support her during this time.
So I think one of the first and most important things for them is to receive some education around understanding how trauma impacts her behaviour, but also understanding how the dementia is impacting her memory and thinking and behaviour as well. Because if they have a level of understanding of that, then the behaviours become less frightening to them, and they're also more likely to be willing to support their mother in it, rather than perhaps take a blame stance or find it difficult to be with her. So education informing them about what the approaches that you are being used in the care home to manage her are, so that there's some consistency across people in terms of how they're approached. Having some sort of agreement that if she is highly distressed, and again, I know this happens routinely, but sort of they can be contacted. They're a point of contact that can come in and be a reassuring, familiar face for them. Also, I think supporting them, just reassuring them that she is being cared for well, that you are looking out for her, that you're answering any questions that they might have, being open and upfront about that and what's happening and going on is going to allay some of those fears. And again, we know it's a bit similar to people with dementia, is a bit similar to young kids, that if the parents are really hyped and agitated and upset, then the children are going to become very hyped and agitated, upset as well. And that's very true for people with dementia as well. So as much as possible, the people around them remaining calm is going to help them to calm down.
Yeah, it's a great point. The strategies for the resident, for the carers, but also for the families that we're looking to provide. Richard, you mentioned that one of the things that stood out for you in this case study was her lifelong trauma history. Why are things that could have happened 60 years prior to her of relevance as you are transitioning her into aged care?
I guess I was thinking that if you didn't have that information, how hard it would actually be to manage someone like this. So the importance of gathering that information is really clear in this case. The difficulty with male staff, the resistance to personal care. If you didn't have that trauma information, if you hadn't gathered that somewhere, you'd just be so bemused about why this lady was behaving like she was. So it is just so important, even though it was 60 years ago. It doesn't matter. That's her life. That's her life story. And gathering as much information as possible around that is so important. Sometimes it's really difficult to get history. We've got people who have dementia. Their long-term memories are often pretty good. They're often very happy to engage in discussions about the past. It's much easier for them than more recent things. And one thing that's worth noting is that if you take a history around lifetime traumatic events, I think staff would often feel a bit scared of doing that. They might think it's traumatizing again for the person. But in my experience, delving into some of those more difficult issues and in a sympathetic and empathetic way, it's often very welcomed. And I think that would be the same for new aged care residents. They'd feel better understood. I think it would actually enhance their sense of safety in the accommodation. So I would certainly encourage staff to not be afraid to inquire. And frequently that may require some very careful collateral history obtained from family, allowing for confidentialities and all those sorts of issues. But I think the key is gathering as much information, particularly at the point of entry. I'm scared I'm going to use the word admission because it sounds so medical, but the point of entry for the resident to aged care, I'm sure it's so important to gather as much information as possible. And trauma is just another example of gathering that information. And wouldn't it be lovely if every aged care resident had a kind of little vignette like we developed for Louise there? If that was readily available to all staff, even if they didn't know her well, just to have those really salient points detailed as they were providing care to her.
I think that's a really good point, Richard, because it actually speaks to that main goal of trauma-informed care, is that the whole of the organisation is informed about the vulnerabilities of this person and about the fact that they've suffered some sort of trauma. They don't need to know the details, but that they're mindful about how they need to act around them to support them and keep them safe.
And that observation you've made, Richard, is that often people can be really concerned about listening to someone's trauma stories. When you're being intrusive, when you're asking too much, how do you contain those? How do you control distress? And we know that can be very confronting for carers and for family members, and that is some of the training and strategies that we'll go into in later webinars, because it is a really important component of being able to understand and support people who have been impacted by trauma. And it may maybe traumas that have occurred many, many years ago but have been resurfaced, and maybe ones that they've not spoken about either for a long time or perhaps not ever before. Thank you for those observations on the case vignette. And just a reminder to people, if you have anything that you'd like to ask about that particular vignette, or if you'd like to make some observations about similar cases or concerns, that you can pop those into the chat and we can talk about them in the last session. Thank you very much to Jane and Richard. And I'd now like to introduce Mr. Ash Kutush.
Hi, Nicole.
Hi, Ash. So Ash is the Service Manager of Program Delivery with Dementia Support Australia. He joined Hammond Care in 2016 as a dementia consultant with a severe behaviour response team, and he's worked with DSA since its establishment. He's a gerontologist with physiotherapy training. He's a member of the expert reference group with the Australian Physiotherapy Association on Dementia Care, and he's been closely involved in the establishment of the National Needs-Based Assessment Program for eligibility into the Specialist Dementia Care Program and the development of the Dementia Engagement Modelling Program. Welcome, Ash. Firstly, can you tell us a little bit more about Dementia Support Australia?
Sure. So Dementia Support Australia is a Commonwealth-funded program that is offered nationwide. It is a 24/7, 365 days a year support to residents and clients living with dementia in community in residential setting. We offer this support through our national helpline, which is the 1-800 helpline, where carers or staff that are supporting people living with dementia can call at any time, as I mentioned, 24/7. We also offer on-the-ground support through our 3 services. The first one is the Dementia Behaviour Management Advisory Service that provides support to people living with dementia with mild and moderate behaviours and psychological symptoms of dementia, living either in community or residential setting. And if the behaviours are severe to very severe, then we offer support through our severe behaviour response team, which majorly caters to residents living in an aged care setting. And more recently, we also have the needs-based assessment, which assesses for eligibility into the Specialist Dementia Care Program for clients who are experiencing very severe behaviours and psychological symptoms of dementia.
Great, thank you. And can you tell us a little bit more about the services or support that you're offering in particular as part of this government-funded program?
Sure. So as part of the package, DSA will be supporting or providing access to Dementia Engagement Modelling Program. It's again a free service that is offered to residents, staff living in residential setting. And the aim of the program is to collaborate with lifestyle and care staff to develop some tailored strategies and activities for engagement and providing some resources so staff can deliver those engagement activities as well. We found that a lot of the care homes that have either been in precautionary lockdown as a result of COVID, or they had an outbreak of COVID. They've had a lot of residents who've been experiencing, as you mentioned in your discussions as well, that isolation. They've felt withdrawn because they don't have access to familiar staff. They've been supported by staff in PPE uniforms, so there is no sense of familiarity. They've also lost contact with family members and other residents as well, as a result of which a lot of the residents have been experiencing withdrawal symptoms. So this program is there to offer support through engagement activities for them.
Yeah, great. And it sounds like some really direct practical services that you're able to offer to an industry which has been really hard hit by the COVID-19 pandemic. I'm wondering if you could just give us a couple of short examples of how these types of services and support have been useful in facilities that you have been supporting in Melbourne who were particularly hit by the pandemic last year.
So last year, I think no one was prepared for a pandemic, and when it hit, especially in residential setting, it took everyone with surprise, and no one really knew exactly what to do. And what we saw in terms of referrals coming into DSA to support residents and people living with dementia in either in community or in residential setting was a lot of the care homes went into lockdown. A lot of these residents were in their rooms, isolated from their family members. from other residents. Staff also got infected, which meant they were either agency staff or they were staff from interstate that had to fly down into Victoria to provide support into the aged care sector. As a result of all these things, what was quite commonly found was that for a person with dementia, we expected them to stay in their room by themselves with no form of engagement, which again, for any person, whether you have dementia or no dementia, would find it very difficult. So DSA utilized strategies very similar to what was being discussed for Louise. We developed very accessible, practical tips of the person's social history, so the staff could quickly understand what was the person's history, what were their likes and what were their dislikes. And based on that social history, we provided access to some engagement opportunities, whether it was through use of iPads or tablets, so the resident could engage with their family members through a video call, or we use music engagement where we provided some iPods with tailored music to the client's need, only loaded onto that device so the resident could listen to that music. We also offered support through using child stimulation or child representation, which is use of dolls and use of plush animals as well, which we found had great success in residents staying engaged.
Great, thanks, Ash. Some really great examples there of practical examples, as you're saying, that someone like Louise we may have been able to use, but ones you've been using over the last year. And finally, if people are interested in your services, what's the best way that they can get into contact with you?
Yes, so if any care home that's been impacted by a breakout of COVID or they've been in precautionary lockdown, they've got residents with dementia who or might have a suspicion of dementia or cognitive impairment that are either experiencing mild behaviors or might be at risk of developing behaviors because of the isolation, they can contact 1-800 helpline, so that's 1-800-699-799, and talk to a consultant at any point in time and discuss the inquiry. Also on our website, dementia.com.au, there is information on the program that I talked about, so you can understand what the program is offering and what support we can offer.
Great, thanks so much, and we will provide those details as well at the end in case anyone has missed them. Thank you, Ash, for talking us through those. I'd now like to invite the rest of the panel to join us for this final section, and this is where we do some Q&A. So please, if you have any questions, make sure that you put them into the chat line for us. First of all, we have a question from Sue, who's asking, I believe it's very important to know the type of dementia a person has in able to provide the correct type of care. How is the type of dementia assessed? Richard, would you like to tackle that one first of all for us?
That's a good question, isn't it? I guess I've put my foot in it, haven't I? Giving the information about each of the dementias and how they're all different and how that's relevant to the care of the person. I guess everybody comes with different histories, so sometimes there will be a formal diagnosis of the type of dementia with the resident. For others, there won't be. I guess this is where in aged care we really, myself as a doctor, I mean, we really need some more medical input into aged care for these sorts of issues. We need more expertise around these issues of diagnosis and around staff education. Jane's a neuropsychologist. She may like to comment on the role of neuropsychologists in terms of this, but often the kind of profile of symptoms with a brief history could indicate one of those 5 types of dementias that really make up the bulk of dementias. So I guess we're working with an inexact system. As a doctor, I like accurate diagnoses, and I guess I would hope that my GP colleagues who are involved with the care of people in aged care have those skills. But this is probably an area we need to work on. I think Sue has nailed one of the big problems, the understanding of dementia and the ability to assess and accurately diagnose is an issue in aged care facilities.
Yeah. Jane, would you like to add anything? Yeah.
Yeah, look, I think at a community level, the aged care assessment services are set up to to be those diagnostic centres. There's other doctors and specialists that will do it as well. But the importance of that multidisciplinary approach, I think, is really important, that there is a full medical review that excludes other contributing factors to cognitive decline, that wherever possible a neuropsychological assessment can help to identify profiles that are diagnostic indicators of particular types of dementias, and that helps to go towards making that diagnosis. So I think, the options when people are in residential care is that they are getting referred out either to a psychiatrist or neurologist for a full workup around dementia, for that assessment to be completed, really.
Thanks. And so I've got another question about how can you support the family and staff who may be exposed to traumas that have resurfaced for residents? Ash, have you got anything to say on that particular topic?
So I think, as Jane and Richard highlighted in Louise's example, is one of the key things definitely is for staff is to know the social history of the person and what is the person's life story. Even responding to the question previously, as much as it is important to know the type of dementia for a person, for medical management, for non-pharmacological support, you do really need to understand the person and their life story to be able to provide some of those recommendations, especially with what the person will be experiencing. So I think for the staff, as it was in Louise's case, it is very important for staff to know what is the person's history, because then they can understand why the person might be reacting to a situation, because they might be able to understand their perception of that situation. For example, in Louise's case, if a male carer is providing her with personal care and she responds with physical aggression, they might understand that it is probably related to a past trauma. And I think that's where the personal history comes into play. For families, again, I think it is very important to provide that information to the staff so they can provide better care, because they will understand the person a lot better and they will understand their reactions a lot better to a situation which the person with dementia might find quite distressing, but we might not understand without knowing what the person's history is.
And I think there's a sort of a follow-on question about one we've had through the chat line. We've always been taught to work within the reality of the person living with dementia and not drag them back into our reality. How does this transfer to trauma? Jane, are you able to comment on that at all?
Yeah, look, I guess at first glance it certainly seems a bit paradoxical at some level, because we will be wanting to distract them at some level, but also remind them that this is in the past and that they're not in any danger at the moment, that they're safe. But look, I do think that it is possible to do both of those things, that you are allowing them in terms of good memories to maintain their links to those. But when they're highly distressed, you are reassuring them and reorienting them to the present in order to ensure that sense of safety. Mm-hmm. And I see them as working together, really. It's not that you're constantly keeping them in the present in order to avoid going back into the past, but it is about managing their distress when they are caught up in a trauma memory, of actually bringing them back to the present and helping them understand that they are safe, that they are not in danger, that it's not happening, it's happened in the past. And then specialist counselling support, I think, if that's an ongoing feature of their presentation, is really important. And that might include the family members as well, in terms of helping to manage that.
Yeah, and I think it's one of those points you've already made, how important it is not just to be dealing with the distress of the resident themselves, but also the impact of that distress upon staff members and also family members. You need to be able to have strategies to contain how you react in your own distress so that you can appropriately support someone as well, particularly when you might be hearing or supporting them through, hearing difficult stories or supporting them when they are really quite distressed and agitated. Bron has asked a very good question here. How how should we think about an appropriate balance between knowing someone's history, so their trauma history, and being able to care for them appropriately whilst also protecting their privacy? So there's this little bit of a balancing act here. Richard, have you got any comments on that?
I probably lean on the side of having information. So we always have to be respectful of people's confidentiality, but I think giving people an opportunity to tell us about themselves, which might be the good, the bad and the ugly, the traumas included, I think is probably more important than, I think sometimes those sort of fears that staff have of breaching confidentiality, I sometimes wonder if they're actually an excuse to not explore some difficult past experiences with residents. I think most people actually welcome the opportunity to talk about things. They welcome people to understand them. And we've got to remember, these residents, the staff become almost like family for them. They're more than family. They're their carers, they're their confidants, they're their friends, they're their day-to-day social contact. So it's a very close and personal relationship that's often established. And I think we don't want to hide too much behind kind of clinical confidentiality. I think be respectful of that, but I think never be afraid to ask. I think people want to be understood by those who are caring for them.
Thanks, Richard. Jane, did you have something to say?
Yeah, look, I think in addition to that, it's important to realise that you don't need to know a lot of detail. You know, a summary like was in Louise's vignette is enough. It's not that you need to know every minute detail and the individuals involved and all of that sort of information, or even exactly what happened with her. I think for you to be able to support her, I think the second thing is, you know, our health privacy acts really provide for opportunities for those involved in care to share information. And so as long as you're working within the bounds of that, I think there's an element of a certain amount of information that is able to be exchanged between those involved in caring for someone. Some of that would extend to aged care, although I'm not as familiar with the aged care legislation.
Okay, I'm just going to we just have about 1 minute to tackle a final question. What about the management of disclosed traumas that may have been caused by family members that are still involved in their life? So, you know, for the resident, how do we go about managing those? Richard, got any comments on that?
Wow,
That's
a huge topic in a minute, isn't it? Yeah. I guess there's always personal sensitivities that have to be weighed up against legal requirements. Yeah, I don't know if I can do that one justice in a minute. Maybe we put that on the list for a separate webinar. It's a great question.
It is a great question and a difficult one, and I think that it is one we can highlight for tackling when we think about disclosures of trauma and how you can go about managing those. Look, we have come to the end of our time. It goes so fast, doesn't it? So I'd like to thank our panel very much for joining us, to Ash, Richard, and to Jane, and for your expertise and your insights. It's been a pleasure to have you here and as part of our panel today. So just as we're finalising our webinar, we're about to launch a poll which you can access in the Q&A section below the video stream. We'd really appreciate you completing. It's just a brief 3-question poll and helps us to improve our services and future webinars. While you're completing the poll, again, I'd like to thank you all for taking the time out today to attend and learn about the impacts of dementia and trauma in aged care. I hope you found it informative and helpful. The recording will be on our website if you'd like to refer other work colleagues to view it. Thank you again to Ash, Richard and Jane for sharing their expertise with us. We do have more webinars planned. The next one will be on the 28th of April, when we will be discussing applying trauma-informed practices in aged care in more detail, and we will touch on disclosure of trauma at that time. And on the 16th of June, we'll focus on supporting staff wellbeing, an issue that can be easily overlooked amongst the busy aged care workforce. Over the next few days, we'll email you a link to the recording of the webinar, as well as more information on where you'll be able to access a range of resources and training over the coming months as they are developed. You can see on the screen now that there's information about where you can find the Phoenix Australia information, but also where you can find out more about Dementia Support Australia and their helpline. Thanks again for your time today, and we hope that you stay in contact and join us for future events. Thank you.